Greetings and happy Halloween. Welcome to Hangouts with HIVE. Today's topic is offering PrEP and family planning. Greetings and happy Halloween. Welcome to Hangouts with HIVE. Happy Halloween. There's an echo. All right. It's gone now. My name is Yamini Oseguera-Bhatnagar. I'm the Power Health Coordinator at HIVE, a hub for positive sexual and reproductive health. It is the 31st of October, 2016, and I'm broadcasting live from San Francisco. I'm joined by some wonderful colleagues today, and without further ado, I'd like to introduce them to you. Let's start with Shannon Weber. Hi, Shannon. Shannon Weber is the director of HIVE and the founder of PrEP.org. She is passionate about creating a world where women have sex and babies when, where, and how they want to. Thanks for being with us, Shannon. Dr. Nika Seidman is an obstetrician, gynecologist, and fellow in family planning at the University of California, San Francisco. Prior to fellowship, she was a clinician at HIVE and the National Perinatal HIV Hotline. Her research focuses on integration of HIV prevention and family planning services. Thanks for joining us, Dr. Seidman. Lisa Stern is a nurse practitioner and vice president of medical services at Planned Parenthood, Northern California. Lisa also holds a master's degree in history with a focus in the history of healthcare and reproductive justice. Super awesome. Thanks for joining us, Lisa Stern. Chelsea Iwamoto began her career in reproductive healthcare in 2004 as an HIV test counselor. She has been with Planned Parenthood Monte since July 2012. Welcome, Chelsea. Brenda Wolfe works to develop new clinical initiatives in efforts to expand services and support patient advocacy for women's sexual and reproductive health care at Planned Parenthood of Illinois. She continues to provide HIV medical care at Mount Sinai Hospital's Maternal Child Clinic, where she began her work 16 years ago to decrease vertical transmission from mother to baby. Thank you for all your work, Brenda, and thanks for being here. Alissa Perrucci is the Counseling and Administrative Manager at the Women's Option Center at San Francisco General Hospital. She is the author of Decision Assessment and Counseling in Abortion Care, Philosophy and Practice. Thanks for joining us, Alissa. Last but certainly not least, Abigail Caldwell is an adult and women's health nurse practitioner and the director of primary care services at Planned Parenthood of Southern New England, which includes 17 health centers in Connecticut and 1 in Rhode Island. She has helped develop centers in Connecticut and is currently expanding PrEP to additional centers with the goal of providing PrEP at all 18 centers. Thank you, Abigail, for joining us. And I thank each of you for taking the time out of your schedule to be here today and for teaching us and telling us what you've learned through your work over the past many years. A little bit about HIVE. Since 1989, HIVE, which is the former Bay Area Perinatal AIDS Center, or BAPAC, has provided preconception and prenatal care to women and couples affected by HIV. Since 2004, all babies born in San Francisco have been free of HIV. Our mission is to advance reproductive and sexual wellness for individuals, families, and communities affected by HIV in San Francisco and beyond. And our vision is to see a world where people affected by HIV have safe pregnancies, reproductive autonomy, access to state-of-the-art health care, and enjoyable sex lives. Thank you. A couple of tips for our viewers before we delve into the content of the hour. We're going to broadcast for the next 60 or so minutes. During this time, as you listen, please think about questions that you may have for our panelists. And so you can ask those in 2 ways. One is by simply typing them into the comment box on the YouTube page. We can engage in a conversation there also. And the other way is to text this number, 415-842-2722. Again, that's 415-842-2722. If you like what you hear, and if you're on Twitter, join us with the hashtag #Where'sMyPrep. Again, that's hashtag #Where'sMyPrep. And if you missed this live broadcast and you're watching the recording, go ahead and click on the front or back slides to be directed to a list of resources and other tips from this Hangout. So with that, I'd like to invite Shannon Weber to tell us, first of all, why PrEP? Why women? Why family planning clinics? Why women's healthcare providers? Shannon, take it away.
Awesome. Thanks for Yamini. I'm going to start my why are we here by saying this is my Halloween costume, where I'm envisioning a world where we crown nasty women and where women don't have to wear a no grab zone. So one, to explain the costume, but just to say that's our vision for this world. And I'm delighted to be surrounded by a group of nasty women here today. So why are we talking about women in PrEP? So 1 in 5 new diagnoses of HIV in the US is to women. And 64% of those women are Black or African American women, even though Black and African American women make up 13% of the population. So this women in HIV, it really magnifies many of the health disparities that exist. The CDC estimates that 468,000 women in the US could benefit from PrEP. This is nearly the same number as of gay or bisexual men who could benefit. You hear much less about women and being able to benefit from PrEP. And then why family planning providers? Well, both women have said that they want to hear about PrEP from trusted providers, including family planning providers. And we know from surveys that family planning providers believe that HIV prevention is part of their skill set. And we know with their skill around planning that they would be particularly adept at offering PrEP to to women. There's been low uptake of PrEP among women. Only about 19,000 women, it's estimated, have started PrEP. So really, to me, this webinar is about, if there's 468, minus 19, it's about 450,000 women who still need to hear about and be offered PrEP. Lots of training and infrastructure support, of course, needed to support family planning providers and to support women in making these decisions about PrEP. And so these Google Hangouts are some of our efforts to highlight the champions around the country who are doing this work so we can rapidly learn from each other. From our Please Prep Me experience, pleaseprepme.org is the location responsive California PrEP provider directory, and we have about 230 clinics listed now. 43 of them are Planned Parenthoods. And then with some pioneering work with Dr. Nika Seidman in San Francisco, we've just developed this Women in PrEP, Please Prep Me card, which we'll link to in our links. But I'm really proud about this because we've tried to create some we messaging about who are we as women that might benefit from PrEP. So that's why we're here and who we're aiming to reach. Thank you, Yamini.
Thank you, Shannon. That was really cool. This PrEP for Women card is very exciting. I also want to say that we have just created collaboratively a pretty inclusive PrEP for Women resources page on the HIVEonline.org website. I'll go ahead and share that at the end among our resources, but it's a collaborative effort. And so I invite you all, folks watching as well as our panelists, to add to this page as resources, articles, toolkits become available in rolling out PrEP for women everywhere, including in family planning settings. With that, I'd like to go to Dr. Nika Seidman, who will tell us a little bit about some pretty awesome research that she's been engaging in, as well as her experience at New Gen Health Center here in San Francisco, offering PrEP to young women. Dr. Nika Seidman.
Thanks, Yamini. And I just also, happy Halloween, everyone, and especially thank you to all of the other panelists. It's really an honor to be on here with you. I wanted to start by adding to what Shannon was saying. Shannon gave us a little background around why it makes sense to offer PrEP to women in family planning clinics, and a little bit about what we know about family planning providers and their interest and excitement about providing PrEP. But we did some recent research about what family planning clients presenting to family planning care know about PrEP to try and get a better sense of what is the magnitude of the problem and what kind of work do we need to focus on first. So what we did was a survey of about 2,000 women presenting to family planning clinics in the San Francisco Bay Area. And this was an anonymous survey on iPads before women entered their family planning visit, and we asked them some really basic information about their demographics, but our main key questions were to get a sense of what were women's knowledge of PrEP, what were their attitudes about learning about PrEP on the day of their family planning visit, but also what did they expect when they came to a family planning visit in terms of integrating sexual and reproductive health care. And then the last question we asked was, again, specifically, were they interested in PrEP that day? So our 5 clinical sites were 3 that were affiliated with San Francisco General. We had our family planning clinic that's embedded in our gynecology clinic, our abortion clinic, and then New Generation Health Center, which is a youth family planning clinic a little bit away from our safety net hospital, and then 2 Planned Parenthood sites. And what we found among the 2,000 women who responded was, first of all, 1 in 4 of those women exclusively access reproductive health care. So what we meant by that is that these women were only accessing care either through their family planning provider or perhaps other pregnancy-related care. We had a very diverse group of respondents, racially and ethnically, and women were young. Their median age was about 25. I think the most striking thing, and what I really wanted to emphasize in this study, was that 7% met CDC eligibility for PrEP. And what the CDC has defined as quote unquote eligibility is women who have had condomless sex in the prior 6 months with a man who's living with HIV, a man who injects drugs, or a man who has sex with men. And we know that those criteria are not perfect, and there are lots of ways to talk about PrEP eligibility. But it was really striking that when we think about the 468,000 women and where they access care, a disproportionate number are accessing family planning care. And of those women, a large chunk of them are just seeing family planning providers. So it really makes sense to provide education and services through those clinics. We also asked women what they knew about PrEP. And across the board, people had never heard of it. I think our highest, on average, about 15% of women had ever even heard of PrEP. And what was really just unfortunate and scary, despite what we know about the epidemiology of HIV and Black women being disproportionately affected, Black women knew significantly less about PrEP than white women, for example. We asked, second, what did people know about, and what were people interested in on the day of their family planning visit? And universally, people said they expected integrated sexual and reproductive health care, that they wanted to learn about HIV prevention strategies and STI prevention strategies, even if they were coming in for a pap smear or an IUD or whatever, or preconception counseling. And then the last question we asked was, are you interested in learning about PrEP today? And I have to say, I think it's really important to put that question into context because, again, these women didn't know anything about PrEP. They didn't know it existed. And we really, up to that point in the survey, had given them no information about it. So what we found was about 1 in 3 to 1 in 4 women were interested in learning about PrEP that day. And while that might sound like a low number, it's actually, in the context of people knowing nothing about this new prevention method, pretty high. So I think our next steps are to try and understand how can we talk to women about this and spread information in a way that is respectful of what they're interested in learning about that day and want to learn about that day, and making sure that everyone really has equal access to this information. So with that, I wanted to spend my last 2 minutes, 2 minutes, Yamini? Hopefully, talking about the New Generation Health Center, which is a family planning clinic that's affiliated with San Francisco General and that specifically tries to reach young people. And I really am going to defer to the rest of the panel to talk about some of their specific implementation efforts, but I wanted to mention a story that really motivated our clinic to talk about PrEP. We had talked about it in general at trainings, but there wasn't like a lot of motivation or energy around it until this winter when we had a client who was a long-standing client of our clinic. She came in regularly for sexually transmitted infection testing, for contraception care, and she just had so many points of contact with our clinic. And at those points of contact, we talked about family planning care in the broadest sense, ranging from sexual to reproductive health care, but we never talked about PrEP. And in the winter, she came in for a series of visits asking for STI testing. and at every couple month intervals. And at the third one, she was diagnosed with multiple STIs at the same time, which was new for her. And so when she came back for treatment, she wanted an HIV test, which we did, which turned positive. And that was a real blow to our clinic, because this was a young woman, 21 years old, who we really hadn't labeled as being really high risk or in any type of category other than all of the clients that walk into our clinic. And I think that was a shock to our clinic, and really made us rethink about how do we think about risk, and how do we offer HIV prevention methods and not make judgments and really try to get information from women, as opposed to trying to label people as high or low risk or eligible or not eligible for PrEP. I think the thing that was the hardest for our clinic is that when she then went to get her HIV care, they asked her, "Oh, had you ever heard about PrEP?" And she said, "No, I hadn't heard about it, and I certainly would have been interested, at least in learning more." So what that has motivated our clinic to do is to start with low-hanging fruit. What our clinic is really good at is sharing information with youth. And so what we've tried to do is do trainings primarily with our health educators, and to use the palm cards that Shannon talked about just as a start to talk to almost everybody, just to get the word about what PrEP is, and then help people engage and think about what is their risk, and engage in further conversations with health educators and providers. Just to give an update of where we are in terms of PrEP, we don't provide PrEP on site yet, and that's for a variety of reasons, but we have a very close affiliation with San Francisco General and a warm handoff system, and that's what we've done so far. So thanks, Yamini.
Thanks, Dr. Seidman. Your work at NewGen and many other places is very inspirational. Thank you for sharing that story. I think it really brings us back to why we're all here today, why we're having this conversation. We definitely want to provide PrEP before it's too late, right? So I would quickly like to move forward and hear from Lisa Stern at Planned Parenthood NorCal about the work that's going on there. Lisa?
Thanks, Yamini, and thank you everyone for being here and participating in the conversation. So when we organized this webinar, Yamini asked us to kind of think about where our PrEP journey began and what our PrEP journey looked like as organizations. And when I thought about it, our PrEP journey here, it sort of started in 2014 with developing protocols and trainings, but in fact, it really starts historically a few decades earlier. And I think that as, the Planned Parenthood affiliate in Northern California, we, started HIV testing really early in the epidemic, and it's been a huge priority here, partially geographically and culturally, but I think for all of us in family planning, this speaks really deeply to us of our mission and why we're here and the care that we provide. So I want to talk you through a little bit of the work that we did in order to get PrEP started in our health centers. It was a few months lead up process for us, and then I'll also talk just a little bit about what our experience has been in the past, being about 14, 15 months that we've been providing PrEP. So as those of you who work at Planned Parenthoods or are familiar with Planned Parenthoods know, we don't, as affiliates, have to develop our own medical protocols. Those come to us from our national office. And then we figure out, based on the specific tests that we do, the specific clients that we see, our local laws and regulations, how to put those into practice in our own centers. So we were very fortunate to have evidence-based protocols already that we could tweak and make real for our clients. And so we received those in 2014, and then really right away started the work of figuring out what we would do to get PrEP out there for our patients as quickly as we could. And the piece that I really want to emphasize is that in any setting, this is always really going to be an all hands on deck effort. And so your educators who may be out in the community, people who are out talking to students, people who are talking to donors, all need to know about important work like this, so to make it as seamless as possible as an organization. And certainly on the service delivery side, what we know from a lot of experience, and I'm sure many of you who implement new programs do, is that the medical piece is really a small piece of it. And you can have the best, clearest protocol in the world, but being able to anticipate the questions that will come up from patients about side effects, about payment, about which pharmacies have the meds, about how to talk to their partners about PrEP, about how to talk to their families. Those questions are so important, and being able to anticipate those and get some information out there already to health center staff so that they wouldn't be, caught in the moment without background was really important to us. So we developed training materials in a few different formats. One is a video that we still have that new staff watch, and the other was a set of training materials. And I have a set here, and we can definitely make these available on request afterward. But they kind of walk through the basics of, what is PrEP? Why are we offering this to our patients? What's the medication? How effective is it? How do you take it? Sort of what does the visit look like? Kind of who does what? What are the questions you ask? How do you document it? And then quite a bit about the Gilead Medication Assistance Program, which has been a really important resource for us in California. Many of our patients who are on public or private insurance do have coverage for Truvada, but we still see about 50% of our patients who are uninsured or whose insurance is just our sort of, Medicaid waiver family planning extension, which does not cover Truvada. So we've been accessing that program a lot and had a lot of support from Gilead in doing that. This talks about labs. You'll see there's a cross-out section as we're switching over. One of the things that we learned was that sending fourth generation tests out to the lab and receiving those results and getting clients back was really causing delays in care. So we're switching over to a rapid fourth generation test tomorrow, 11/1. So we've had to update our materials to account for that. I'm happy to talk about that later. Talks about billing and everyone's favorite, billing and coding, and then how to follow up with patients and what's the schedule of follow-up visits. So these materials were, reviewed at staff meetings in advance of rollout and then have been available since. And we had input from our call center, input from our trainers, clinicians, medical director, of course. One thing that I really want to emphasize too is just the importance of talking with your local partners about your plans. We've had an unbelievable amount of support from Dr. Seidman in particular, who's on this call, but from many other local partners and organizations. If we had to do this over again, I think one lesson learned is we probably could have done even more kind of publicity. I think we were really shy about wanting to make sure that we had everything perfectly in line. And now we've been out there talking more and are seeing a greater volume of patients. But seeing more patients early on actually can sometimes help in the learning process and not make it a scary one-off service. And we made the decision, I know people think differently about this, but we rolled out in all of our health centers all at once. And partially that was because we happened to have a meeting where we were going to see everyone together, but it was also because we really wanted to emphasize to everyone that this is just a natural extension of the HIV prevention and other STI prevention work that we already do, and that we're already talking to patients about how to have safer sex, about their sexual practices, and it's really a very natural conversation in that context. I think there's a lot more work that we can do. I was excited to see those little cards, but I think there are many more, as Nika's research shows, many more patients that we could be talking to about PrEP. But I can't emphasize enough for all of you how much the provider hotline is an incredible resource, and, just take advantage of the expertise that surrounds you, and, very happy that you're here today. So thank you.
Great. Thank you so much, Lisa. There's great work going on at Planned Parenthood NorCal. Thank you also for echoing what Dr. Seidman was saying, which is the importance of really talking to patients. And I love that you said that this is just kind of an extension of HIV prevention work in the family planning setting, and that it just is kind of an extension of that, and it should continue to happen that way. With that, I'd like to go to Chelsea Iwamoto from Planned Parenthood Monte to tell us the story there. Chelsea?
Hi, Yamini. Hi, everyone. And thank you so much for having us here. It's such an honor to be on this panel and hear everybody's stories. And what's striking me is how similar, especially hearing a lot of what's going on at Planned Parenthood NorCal as far as PrEP implementation, how similar it's been to our story. So, you know, Lisa had mentioned that we had PrEP kind of written into our protocols from the national organization. And when we first saw it there, I was speaking with the lead clinician at our West Oakland site, and we were so excited to implement this service. Prior to that, the sites in Alameda County had been involved in an HIV opt-out testing grant, and our site had finished their cycle, but we'd really taken these life lessons or these implementation lessons from being a part of that program, and had seen how we could really apply it to our PrEP services. And the major thing that really struck a chord with us was that we needed to get buy-in. We needed to get buy-in from the clinicians, from the support staff, in order to make a really successful program. So Planned Parenthood had a training program, and you know, we were all trained in PrEP services. We passed that along to our support staff, but we really wanted to make it even more comprehensive, give them an even more in-depth look of how we could integrate these services in a comprehensive way. And so again, to kind of echo what Lisa was saying, is we really reached out and partnered with different local organizations. We actually reached out to Planned Parenthood NorCal because they had already implemented the services really successfully. So they'd been a tremendous resource for us. And then we also reached out to the Pacific AIDS Education Training Center, and that was, I think, what made the largest difference. When we first presented that we were going to begin PrEP services to our support staff and to our clinical staff, everyone was excited, and there was definitely an emotional buy-in. But I think sometimes it's so important to really make it seem that it's not just one more thing. You know, we're providing family planning services, we're providing reproductive health care, we're covering a lot on the ground in a 10-minute window with our patients. And so while it sounded in theory like this really great service, which it is, it's absolutely a key service of ours now, I think to make it a comprehensive and a operational success, we really needed to bring in some of those local experts who had already been there and done that. So we had asked staff what they needed in order to kind of bring that home for them. And they said they needed more training. They needed a kind of a refresher on HIV and post-exposure prophylaxis as well as pre-exposure prophylaxis. And so with the AETC, they kind of brought that to us and really worked with us on operations and workflow management and really all kinds of things at the ground level to make it successful. So now it's become kind of we have these weekly, quarterly, monthly updates about PrEP and PEP and HIV, and it's starting, we're still kind of in the first flush. We only implemented this past March, and we had quite a large patient uptake for a new service. You know, we rapidly added around 20 patients kind of to our patient load of people receiving PrEP services. And so now we're kind of continuing to bring in new staff and inform them of kind of these services and how to present them to patients, and how to successfully message that they may be eligible for PrEP. And so what we're finding is now focusing on PrEP for women, you know, women make up 80% of our patient kind of load, and where there are very few women that are uptaking PrEP. And where, Dr. Seidman had mentioned that they saw that in the study, and we're seeing it in practice for sure. So I think right now one of our challenges and one of our strategies is kind of planting the seed. It's like with contraceptive counseling. It's like with any type of intervention or, kind of new reproductive health knowledge. It's about planting that seed. And every time someone comes back, maybe it changes, maybe, they're now eligible and they weren't before, but providing them information and letting them really make that decision by themselves or with their provider is our new frontier, I think. So thank you so much.
Thank you, Chelsea. Thank you for mentioning what we call shared decision-making as a very important way to communicate with our patients around these new options. And there will be an article in the resources section after this Hangout that will refer to that as well. Thank you for the great work going on at Planned Parenthood Monte. With that, I'd like to move forward and hear from Brenda Wolfe from Planned Parenthood of Illinois about the story out there. Brenda?
Hello, good morning. I'm really excited to be here among amazing panelists, and I love hearing what everyone's doing. We also at Planned Parenthood of Illinois, we rolled out PrEP services about a year ago. It didn't really get up and running as quickly as I'd liked until about maybe 3 months after we really started. But what I think I want to spend some time on talking about is that initially, when you think of PrEP, we think of it as a clinical service. And as a clinical person, I think about, rolling out and all the medical standards and guidelines and things along those lines. However, there's a lot of logistics that go out administratively, and I'd like to really discuss those. So for instance, when we first started to roll out PrEP, we needed to make sure that we had the staff and the stakeholders buy-in, and I think Chelsea mentioned that as well. We actually had to educate the board of directors what PrEP was. And so we realized that this was just because clinically we know what this is, the other population, the community may not. So we did that. We also had to identify the cost for PrEP for people who do not have insurance because Title X doesn't cover this. And so we needed to come up with what we were going to charge the patient, how much the labs were going to be, were we going to script out. Then we had to identify billing codes and diagnosis codes. So we, of course, we picked, the 20.6. But the reason that was important is because when we went to evaluate the program, there were several different diagnosis codes. And so we're trying to pull up by Truvada, and they're like, well, no, now we've got PrEP and PEP. And we really wanted to know how this new service was going. We wanted to know about PrEP. So we had to really choose a diagnosis code. We also had to create standing orders for labs and medication modules as well. And then we had to update our next gen EMR to make sure that we had all of those labs that we would be doing or medication modules. And then we created some my phrases because when you do, as you know, PrEP rollout, there's a lot of education and then there's a lot of documentation. So we created my phrase for PrEP and PEP for initial visits and also visits for reoccurring visits. We also had to educate the support staff, the schedulers, the educators, the call centers, as well as our centralized follow-up, because now we were getting, fourth generation tests where before we were doing third generation tests were actually done in the clinic. And so they're like, why are you all of a sudden ordering so many fourth gen tests? And so that was important. We had to educate people along those lines. We also had to make sure that our marketing material was appropriate. And we wanted to make sure the community knew. So we had to get the marketing team on board for their brochures and adding the services to our website, as long as, our handouts, our palm cards, things along those lines. We also wanted to create pre-populated assistant programs as for Gilead. Gilead, we would need quite often for patients' assistance. So what I did is I pre-populated the forms and then I printed them out so they would actually be available to the clinicians very, very quickly. And when we rolled this out, finally, when we got to the clinical piece, what I did is we had a 90-minute clinician lecture presentation, and I really provided several case studies that went from PEP to PrEP so they can feel like they put it in practice. So that's kind of the administrative part. I did evaluate the program, and what I found is actually after the first 3 months of rolling this out, I was able to identify the clinicians who were not prescribing PrEP. So of course I paid them a visit to figure out what the story was. And I had things told to me like, well, the health department has a handle on it, and they can get the med. And I'm like, yeah, wrong answer. So we had to sit down and educate about that. Some people, no one's asking for it. I'm like, okay, well, you know what? We have to talk about that. It's not something we're waiting for people to ask us about. And then, well, I need to review the algorithm. So we did that. Some of the common questions that I noticed I was receiving is questions about the kidney profiles, because we don't do primary care. So these were some new labs. What do I do if an elevated creatinine level? How high is high? One of the things that I can share is that if you actually hydrate the patient and have them come back in 72 hours, generally, if they're really not in any kind of trouble, the creatinine level will basically go back to normal. If I have someone repeating back and forth, they're starting, stopping, how often do I need to basically draw a hepatitis antigen? And so, of course, it's like draw your antibody and be done with it, and vaccinate if you need to. Can I give PrEP if I have positive syphilis tests, other drug interactions, and several questions along those lines. In our evaluation, 74% of our clinicians had prescribed PrEP. 87% was upstate and 50% downstate provided, which actually showed me that there was more providing PrEP in the urban areas versus the rural areas. I also identified that we had 100 patients visits and 60 unduplicated visits, but these visits, 69% were in men and 29% were in female. Again, Planned Parenthood, I love seeing men, and I'm glad we're increasing that population. However, point being is that we want women to be on PrEP, and why at Planned Parenthood, when we see more women, are we 69% men? So that was a concern of mine. So some of the take-home points were clinicians were in fact interested in providing PrEP. They've really felt that PrEP was appropriate for Planned Parenthood. They feel that they are comfortable with the sexual histories that need to be asked in order to provide PrEP. They felt the 1 hour lecture of PrEP was actually sufficient training for both PrEP and PEP. However, they felt that they would have complete confidence after they saw a patient. 57% felt that PrEP gets a little bit easier every time that you prescribe it. And some of the opportunities for training is I'm going to probably continue to go over some of the lab result questions that I've received over the last couple months, and also consider making sure that we have enough time to provide the initial visit as well as the follow-up visit, because that was one of the main complaints that, how do you have time? And I think it was Chelsea, or actually Lisa Stern, that mentioned that you just don't have enough time in 15 minutes to ask all about the sexual history and do all of the training and PrEP. We do have these visits separated. The first visit is really obtaining information, getting labs, then they come back within a week to obtain their information, but there's a lot of education to provide. Also, we wanted to make sure that we have more support around clinicians understanding the insurances and the Gilead paperwork to fill out. And then I think lastly, I identified that we needed to education around PrEP, PrEPception and pregnancy. So thank you very much.
Brenda, I could listen to you all day long. I mean, that was just amazing. Thank you. And I will work with Brenda to get so much of what she talked about captured in our resource list. So have no fear. Nothing will be lost from this Hangout today. I'd like to move forward and hear from our remaining wonderful panelists. I'd like to go to Alissa Perrucci, who will tell us about the Women's Options Center here at San Francisco General Hospital. Alissa? Oops. Alissa might have disappeared for a second. Abigail, let's go to you and Planned Parenthood of Southern New England. Alissa, we'll come right back to you.
Okay, hello. Thank you so much for having me. So when we began to consider how to roll out PrEP at our centers, we anticipated a lot of the challenges that many of you have mentioned. trainings, medication cost, workflow. And so we really wanted to be prepared, and we looked for support to help us work through those challenges. And so we teamed up with some researchers at Yale University and applied for grant funding to do a PrEP implementation study. And it was approved, and it's now underway. And although it includes men, it really focuses on PrEP for women in the family planning setting. And so as part of the study, all of our clinicians and our center staff were trained on PrEP by some specialists at a conference in June. And now we'll be comparing two ways of implementing PrEP at two of our centers, incorporating perspectives from patients, from clinical care teams, from leadership, about service delivery preferences. So the goal of the study is to improve our understanding of women's unique HIV prevention needs and preferences, and to inform best practice for integrating high quality PrEP care for women into our reproductive services. So when we committed to this study, we also were committing to a strategy of starting small. So we're going to pilot these services at select centers and fine tune them before we expand them to other centers, as opposed to the strategy that Lisa mentioned, which is to, roll it out at all centers all at once. And personally, I really struggled with which is a better approach. Because on one hand, I want to be really thoughtful about a new service and work out any kinks and make sure that we're doing it really well before we're doing it everywhere. And on the other hand, we know that this medication is safe and it's effective. And is it better to just get it out there and get it going and make it accessible as quickly as possible to patients? So I was really kind of thinking about this particularly as I was looking into resources outside of Planned Parenthood. I was looking into, how we could connect patients to additional resources like case managers if they needed additional support. And at one point I just stopped and said to myself, am I overthinking this? I remember I think I was talking to Lisa Stern. I said, Lisa, am I overthinking this? She was probably thinking, yes, you are. But I think, if I were to pick up birth control pills and someone were to say to me, okay, here are your PrEP pills and here's your support group and here's your case manager, I might think, whoa, I just want my birth control pills. So on one hand, I do think it's important that we have those support networks in place for patients, but I also wonder if we treat PrEP as this big, new, different service, are we in some ways perpetuating the stigma of HIV? So, I had some reservations about starting small and going big, but the good news is that we're finding that it's very doable. And we feel like we can quickly go big and get PrEP out to more of our centers much faster than we had anticipated. And there have been a few small kinks that have come up that we've found solutions for quickly. For example, we did find it challenging to efficiently help patients with the financial assistance programs, but one of our center managers developed a handout and a little information packet that we've been able to give to patients to help them through that process, just to make it clear and to save time in the centers. And since starting on PrEP, we've gotten a lot of really positive feedback from staff and from patients on the service. We created a template in our electronic health record that's specific to PrEP. So it includes all the necessary components like key medical history questions or lab tests or counseling points. And so staff have said that that's really made them feel more secure in offering the service because they feel like it's ensuring thorough, safe care while also being efficient. And patients have given us a lot of positive feedback. We've had some patients travel a long way to get to us. We had one patient drive over an hour to one of our centers to get started on PrEP. And he said that he couldn't find any providers in his area that offered it. He called some primary care providers and one had never heard of it and another didn't offer it. So he called some specialists and they could see him, but it was going to take weeks or even months to get in. So he was just so thankful to receive services so quickly from us. So because we're getting so much positive feedback, we're really working now on expanding our services to more centers. So thank you.
Thank you, Abigail. Your work in Southern New England and Connecticut and Rhode Island is really inspiring, and thank you for sharing that. We will now hear from Alissa Perrucci about the Women's Options Center here at San Francisco General Hospital, and then we'll go to questions. Alissa, on to you.
All right, thank you. I think it's good for me to be last because I think I am the beginner of all beginners of PrEP rollout. We are in profoundly beginning stages. So I hope that's going to be useful for some of our listeners and viewers. We had Dr. Seidman and the PrEP team come to our clinic, which is the abortion clinic inside of San Francisco General Hospital, and talk to us about PrEP and about contexts in which we might offer it, and just sort of demystifying the whole process for us. We are an abortion clinic that is used to having research going on and other add-ons to what can be a somewhat complex procedural service. So we're used to having new and novel programs or research that get implemented inside the clinic. So it's not that we are familiar with, but just like any project, I think that we have run into some of the same barriers that we see when we're trying to implement a larger research study that may involve surveys and interviews within the context of people having abortion care. So some of the things that I think that I have taken away that have been extremely helpful are sort of concepts that I think most of us are familiar with, needing sort of an expert that grounds the program. And for us, that's definitely Dr. Seidman. Dr. Seidman is, in addition to being a faculty and attending or being a fellow and attending cases here at the abortion clinic, she is one of our most beloved providers. And so the fact that she is rolling out this program, she's behind HIVE, and the team on this has been, it has helped staff be open to adding this service. So I can't say enough about how, for us, I think for the counselors, when we think about HIVE now, we associate it with her, who we love to see, and we're so excited to see each day that she is here attending. So that's one thing, knowing that we can go to her and that she is here to help us. The other thing that I think has been important, well, it hasn't been important, but needs to be important, is sort of having a staff leader. I think, embarrassingly, that should be me. And so this webinar has inspired me to become that person for my team. It's kind of funny. I think we had the HIVE team. I think we had you guys come and talk to us. I'm actually too embarrassed to try to recall exactly when that was, but it was a while ago. And since then, I think we have offered PrEP to a whopping 3 people. 2 of those I did, and one of them was another counselor who I think felt comfortable adding this service. And it's funny, the third person that I added was after Yamini approached me to be on this panel. So that sort of speaks to how there are many different ways to incentivize someone to become sort of a staff leader. I think the only way that right now I can be a staff leader in this context is knowing that Dr. Seidman is there as an expert, as a medical expert, to back me up. So the way we have it set up now is that I think I can encourage, we use the CDC criteria. I can encourage myself and my staff to sort of look for those women and patients who meet those, who are on their self-report medical history, that they meet those CDC criteria, and using that as a prompt to initiate those conversations. But what's great is that we can then say, are you interested in hearing more about PrEP? And then we can table that, get through all the different things that we need to do for this sort of procedural conversation, and then know that we can go find someone from HIVE or find Dr. Seidman to come back in and see that patient. We're going to use we have many different gaps in the flow for those of you doing sort of having a procedural flow that you know that there is downtime where patients are waiting, those are optimal times to use the flow, breaks in the flow, to get someone to be able to talk to that person. So I think a lot of what we're doing is really trying to build up our capacity for being in this very, very young stage. Thank you.
Alissa, thank you very much. And regardless of where you are in the process, I'm so happy and honored to have you here. Abortion care on its own is hard to do in this country, in this political climate. And so adding HIV prevention and a PrEP service is amazing, and you're doing amazing work. And thank you for stepping into the role of being that champion at Women's Options Center. And of course, we, and I'm pretty sure every panelist on this Hangout today is happy to provide whatever assistance in rolling it out further. I would like to open up for questions, and I'm getting them from all directions, and I'm getting a few comments as well. I just want to highlight a few things. I want to say thank you, Abigail, for really talking about stigma and how you know, sometimes overthinking it or really taking too much time to do this, maybe perpetuating stigma. Lisa Stern was saying in the chat box how PrEP visits are not separate from other visits. PrEP visits, HIV prevention, everything's integrated, right, as a way of overcoming that stigma, and we can talk more about that. Also, folks are interested in the gender breakdown, right? Family planning clinics, Planned Parenthood clinics who primarily see women are primarily providing PrEP to men. So how can we change that moving forward? So lots of really good thoughts, really good questions are coming up, and maybe we can compile them later. But I want to start with a very quick question about missed opportunities. Let's go back to Dr. Seidman. We had talked about that story, and we had heard that story from you, and that very profound missed opportunity there in rolling out PrEP for women in family planning clinics. How can we utilize such missed opportunities as sort of as a systems review of how we can do better? Dr. Seidman, do you have anything on that?
I think that's a great question, and I think we haven't really explored that, but I think all of us know from all of our rollouts of many different interventions over time that having a clinical story really can help motivate your clinic in a profound way, and it doesn't have to be complicated. I think we have lots of really well done, but also really resource intensive ways, in particular from perinatal HIV, Shannon mentioned this on the chat, of looking back at specific instances and learning from them. I think what we can learn from that is that, first of all, probably just doing it at all is one of the most important things you can do. You don't have to have a huge grant and a huge team to do an in-depth review. If you have one case that really got people talking in your clinic, that's worth having a staff meeting about, getting the facts of that case, going through even just that one case, and then using it for lessons learned. And I think what was so striking from all of the clinics on the call who did, I mean, I'm just floored by, honestly, how ahead of the game in many ways family planning clinics are, given the limited support that has really been directly provided to them, and how people are so good at learning along the way from each patient they see and adapting as they go. So I'm curious to see hear from other respondents if there were other specific clients that really changed the way they provide care.
Great. I would like to also get thoughts on just the whole idea, and I switched to Lisa Stern because I wanted to hear from you, Lisa, just around, so folks are asking, and I know it's pretty set at most clinics, but what is sort of the risk category, the profile that of a person that PrEP is offered to in your setting maybe, and let's find out, maybe it's different in different places. Is it being universally offered, or are we using some sort of risk category? Lisa?
Yeah, so I'm happy that you asked this, because I was kicking myself, of course, like after I spoke about all the things I forgot to mention. So one of those was that I think, like many, we've been mostly talking about PrEP with, as Alissa mentioned, you know, people who, as you're taking the sexual history, you're kind of hearing those cues from the CDC criteria. You know, they know that their partner has HIV, for instance. But really, when especially thinking about Nika's missed opportunity case, there are probably more people who either have stuff going on that they're not telling you about, or they don't know their partner status, or maybe they would benefit from some kind of conversation or information, even if it's not a prescription that very day. So that's something that we've really been thinking a lot about. And actually in our new protocols, we added a sentence that basically just gives clinicians and educators a little more space to not feel bound by those criteria, to use those criteria as a guide, but to be, permissive is the wrong word, but just a little more patient-centered, like Chelsea said, to really engage deeply in a shared decision-making process with someone if that's where the conversation goes. So, I think we're all very aware of the time constraints in visits. And so, of course, we won't be able to have a deep personal conversation with everyone, but to be able to just make it known that, like, that's a thing people take. It's not for other folks. It's for anyone who may be interested or who may have cause to use it. I think the way that, Abigail made a good analogy to birth control, in some ways limiting to these specific risk factors is, it's sort of akin to, oh, well, if someone isn't having intercourse that often, maybe they could use condoms. But we know that with birth control, we offer all the options for all the people. And so I think in my, heart of hearts, I think we'll probably get there with PrEP. Anyone who you're talking with about HIV prevention, it probably should be on the table.
Mm-hmm. Great, thanks so much. I quickly also want to honor Chelsea for saying something similar earlier about how this is an ongoing conversation sometimes with patients, just like contraception is sometimes an ongoing conversation with patients. Similar but different, right? Brenda, first of all, I want to really honor you for being just this diehard, tireless champion at Planned Parenthood of Illinois and doing so much work, and there's so much depth to your presentation. There's a couple questions specifically for you. One is around your My Phrases, the questions you're asking. Are they embedded in your EMR, and can you share those? Another is, did you receive additional funding to roll out PrEP at Planned Parenthood of Illinois? And lastly, what are your thoughts around the observation that you've made around women not accessing PrEP quite as much as men, Brenda?
Okay, gosh, so you're gonna have to remind me of those three questions as I go on. I'm sorry. All right, so the first question, what was the first? I already had the answer, but what was the question again? I'm sorry.
About my phrases and your EMR.
Okay. Yes. So yes, actually, I just created them. I use some of the verbiage that's in the CDC that says that things that we actually have to add, and then some of my own things that I think that are important. And then I just basically had them downloaded into the My Phrases of all of the clinicians. I think it was about last year when I realized how much documentation was going to be in NextGen. We created all kinds of My Phrases, anything from a UTI to a BV, and definitely created one for PrEP, PEP, and NPEP. I'm very happy to share them. I can just email them out, and you can just go ahead and have your IT people download them. I think the next question is, did we have any extra funding? No. As some of my colleagues that are on this call, some of you work with maternal child and HIV. So that is my passion. That is my love. So rolling out PrEP was exciting and fun for me. It was easy because that's kind of what how I think. I think, and where a lot of my colleagues have other specialty areas, this happened to be mine. So no extra funding. Just really made sure that I did a really thorough job in educating and thought through the presentation I presented. And then here's my phone number. Call me anytime that you need any questions. And then people were like, okay, we'll go to the MSNGs and we'll contact you if you have any calls. So that's how we rolled out that. And then you had another question.
Yeah, so a couple. So one question came in asking how long your visits are, and the other one I just wanted you to hear your comments on what to do next about the fact that women are not accessing PrEP at the same rates as men.
Okay, we only have 15-minute visits, which frustrate me, and they are basically embedded in the rest of the clinic. So we might be doing a Med AB, we might be doing, a family planning contraception, or we might be doing PrEP. So it's 15-minute visit. I really try very hard to get the powers that be to push that a little farther. But that's probably not going to happen. So we just kind of do what we need to do. And in terms of women, actually, I think that we are failing women in a general area in general. And actually, I'm part of the MIPI planning team, and we've talked about this. I think the marketing really goes. It's a lot of, in terms of MSM, when you see some of the pictures that are out there, and you do see some pictures of women and, heterosexual relationships, but you don't really see this woman standing there strong. Like, I'm a strong woman. I can make decisions about, my body. And if I want to have sex and just hook up, or, if I just want to protect myself and not have to worry about others, I can do that. And I don't think we have any marketing out there that really champions the independence of women to make their own decisions. I think we also need to help some of our women identify their risk factors. I don't think that people always think about the risk factors, especially some of our younger people. They don't think they're at risk. But I always go back to my slides, where the CDC slides, where it shows us that when you look at, the population of MSM, there are men getting infected. It's basically, I think, around 92% from the MSM population. That's how they're getting infected. You roll over to the next slide that says women, and women are getting infected from men. It's 84, about almost 89 to 90% are getting infected from men. So women are getting infected from men who are having sex with men. And I don't necessarily think that women think that way. And it's like, hey, it's a possibility. Let me just show you the statistics that are out there on how people are getting infected. And you shouldn't have to live in fear. You just need to protect yourself, and you can do that. And so those are some of the reasons, some of the things I think we can do.
Great. Brenda, thank you so much. Overall, I think we're all very interested in rolling out PrEP for women in family planning and women's healthcare settings in a trauma-aware and stigma-busting way. And so more to come on how we're all going to do that. I'd like to switch over now to Shannon to give us a little call to action. I know there's other questions that didn't get answered, and we will try to get you the answers to those via the resources that we share at the end of this Hangout. But over to Shannon to tell us what we're going to do next.
Yeah, I want to thank everyone for joining and being brave and sharing your stories in what is really a work in progress. To me, this webinar actually ended up being about leadership. I have a call to action sitting here, which I'm going to give, but really to me, this was like, what does it look like to show up in the absence of support and resource and do what's right for women? And so I want to honor each one of you as leaders, as change makers, and moving this forward. So, wow. So I learned from that, like, start with what you have and get going. Be willing to make mistakes and get feedback from other people, and know your why. Like, why is it that we do this work? Well, we believe you can't end it without women. We believe in women's empowerment, and just like really moving forward with that. But our call to action, I think, for women healthcare providers everywhere is that regardless of the resources that you have in place or the mandates that have come to you, we can all ask all women about their HIV vulnerability. And we're going to get better at doing that as we start doing it. We can discuss pregnancy intentions and reproductive health with all women. We can learn about all the HIV prevention methods that are available. So if you cannot prescribe PrEP right now, you can certainly talk about condoms, treatment as prevention, limiting partners, like all the other options that are out there, and then make a referral for PrEP. And so that's one of the calls to action, which is that if you cannot provide PrEP right now, you can certainly screen and refer to PrEP as part of the prevention options that are available to women. And also really important for us to advocate for PrEP accessibility for women. And I think that includes women being included in clinical protocols, funding announcements, marketing, and making sure that women have the reimbursement and women's providers have the reimbursement to be able to provide PrEP. So onward.
Thank you, Shannon. I just quickly want to say thank you to all my wonderful panelists, Abigail and the Planned Parenthood of Southern New England. Thank you, Alissa and the Women's Options Center at San Francisco General Hospital. Thank you for your work. Brenda, Wolfe and Planned Parenthood of Illinois, thank you for joining us. Chelsea Iwamoto from Planned Parenthood of Monte, thank you. Dr. Nika Seidman, all over San Francisco, but today representing New Gen Health Center, thank you. Lisa Stern and the Planned Parenthood of NorCal. Shannon Weber, my wonderful colleague from HIVE. Thank you all very much. This has been an honor, and may the work continue, more to come. This was Hangouts with HIVE.